Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our next speaker today is going to be Julien Trujillo. He is a student pharmacist at The Ohio State University. He'll be presenting on Alteplase for acute ischemic stroke at 4.5 to 24 hours, the HOPE randomized control trial.
A little bit of a background about the study. It talks about intravenous thrombolytic treatments as well as thrombectomies. Really, kind of the two treatments are Alteplase. And a little bit about a background is that it is, for its labeled use, it's administered within 3 hours of symptom onset. Prior trials, the Extend trial, expanded this therapeutic window to 4.5 to 9 hours. And then looking at tenecteplase, trials of Timeless and Trace3 proved the safety and treatment within 4.5 to 24 hours of symptom onset with patients that had large vessel occlusions. And then looking at like severe strokes or where there's a contraindication for IVT, thrombectomy is the mechanical interventional procedure that removes a blood clot or thrombus under image guidance. And I just wanted to highlight that this is not always an option in low to middle income countries. So that's what the study is kind of looking at as we move forward. And the purpose of the HOPE trial is really to extend the Alteplase treatment window, looking at the tenecteplase through the Trace3 and Timeless. This is really just kind of expanding that for Alteplase with 4.5 to 24 hours of symptom onset to increase eligibility of select ischemic stroke patients, as well as increasing ischemic stroke interventions. So where facilities that don't offer thrombectomy, this can hopefully offer IVT treatment with the extension of this window, and then as well as utilization of CT imaging. And so it is widely used to determine irreversible injury and then or brain tissue that is salvageable. So using this potentially as a marker. The study design of the HOPE trial, randomized, open label phase 3, and then with a blinded endpoint study at 26 stroke centers in China. There was written informed consent that was obtained from all patients and their legally authorized representatives prior to enrollment of this trial, as well as this trial was conducted in accordance with the Declaration of Helsinki, an international council for harmonization guidelines for good clinical practice. And then looking at the inclusion criteria, patients with ischemic stroke and potentially salvageable tissue on CT perfusion imaging presenting within 5.5 to 24 hours after stroke onset was one of the inclusion criterias. And I just want to mention that the midpoint of the time last known to be well and symptom recognition time was used. So patients that may not know I think this goes into waking or unknown time of when this occurred, if it were to be overnight, midpoint was used for that. And then to define what a salvageable tissue on CT perfusion imaging, the buckets were ischemic score volume less than or equal to 70 milliliters, perfusion core mismatch ratio of greater than 1.2, perfusion core mismatch volume of at least 10 milliliters. And then the other inclusion criteria would be 18 years or older, NIH stroke scale score of 4 to 26, and then a pre-stroke score of 0 to 1 on the modified Rankin score or Rankin scale. And I just wanted to briefly go into the NIH stroke scale. This is really used to check stroke severity, and the inclusion 4 to 26 would make it between moderate to severe inclusion that would be indicated for Alteplase administration. And then this was used to compare recovery to display neurological improvement in the trial. The modified Rankin score was used to assess the functional outcomes of the patient. So patients that were included in this pre-stroke score of 0 to 1 showed really no symptoms or non-significant disabilities. And I think this is a nice visual for that. And of course, this is used for functional outcome before and after administration. The exclusion criteria and rescue thrombectomies. This was any patients that failed to meet the CT perfusion cutoffs and the inclusion criteria were excluded, as well as if there was a thrombectomy planned at the time of randomization, or if they just simply had guideline-based contraindications to Alteplase, aside from the extended time window. And this was discussed and decided regarding the decision of if patient should receive a thrombectomy was conducted independently, and that rescue thrombectomy was permitted after randomization in the study. Looking at the randomization and masking of this trial, eligible participants were randomly assigned to either the Alteplase group or standard treatment group using a centralized, secure, web-based system. Randomization algorithm was used to balance the groups based on age, so less than 70 or at least 70 years or older, time from symptom onset to randomization, less than 9 hours or greater than or equal to 99 hours, and then an NIH stroke score at randomization, either less than 10 or greater than 10. And then open label treatment assignment. And then just wanted to mention that and the evaluators conducting the clinical assessments and the independent adjudication committee responsible for outcomes as well as the bleeding events remained blinded. And then looking at the intervention and other procedures, the intervention or Alteplase group would receive the IV dose at 0.9 milligrams per kg with a maximum dose of 90 milligrams. That was that 10% of the dose was administered as a bolus over 1 minute, while the remaining was infused over a 60-minute duration. The control or standardized treatment group received antiplatelet therapy and other supportive care, such as blood pressure care and statin that was based on the same guidelines during randomization. And then patients initially planned to undergo endovascular thrombectomy during screening were excluded, but rescue thrombectomy was permitted after randomization. And then looking at the outcomes, the first one, the primary outcome, was the percentage of patients achieving the non-disabled functional outcome, defined as the MRS score of 0 or 1 at 90 days, or essentially just returning to baseline. The assessments were performed by certified personnel who were blinded to treatment assignments. Patients that were assessed were followed by telephone and audio recordings that were reviewed by trained raters. And then local certified investigators were utilized when buvoids were not available. So the patient didn't have access to electronics or were not able to somehow use a phone was used. And then the following conditions for the primary outcome, the patients who died during the follow-up were included in this primary analysis. And then patients found not to meet inclusion criteria after randomization and who underwent rescue thrombectomy after randomization were excluded from per protocol analysis. The secondary outcome were the percentage of patients achieving independent recovery, which was defined as MRS score of 0 to 2 at 90 days, proportion of patients achieving MRS score of 0 to 3 at 90 days, the ordinal distribution of MRS at 90 days, as well as major neurological improvement of at least 8 points on the NIH stroke scale compared with the initial deficit, or a score of less than 1 achieved at 24 hours and 7 days. And then the safety outcome of this trial was we're looking at symptomatic intracranial hemorrhage within 36 hours, randomization, and then all-cause mortality at 90 days. The adverse events were recorded using the National Cancer Institute's common terminology criteria for adverse effects. And then looking at the enrollment, we started with 3,885 adults total. And then some things to note about the exclusion of who were eligible were 1,946 were excluded either for having a minor stroke or a very severe stroke. 753 were excluded because they were intended to receive the endovascular therapy. And then 428 were excluded due to acute or past intracranial hemorrhaging. So really looking at some housekeeping, exclude things, as well as like contraindications of Alteplase administration. And so after the exclusion, of these patients. We were left with 372 patients that were randomized. And then in each group, we had 186 patients. And then finally, in the primary analysis, we had 186 that were included in both groups, as well as in the Alteplase, we had 179 that were included in the per protocol analysis, and then 171 that were included in the standard treatment. And then looking at the protocol deviations, there were 4 patients for both groups that did not receive intervention that was intended at randomization. And then looking at specific groups, the Alteplase group had 3 patients excluded, 2 received rescue thrombectomy, and then 1 was enrolled inappropriately. And then for the standard treatment group, there were 11 patients that were excluded, 7 received rescue thrombectomies, while 4 were enrolled inappropriately. And then looking at the patient demographics, I want to make some notes on the median age of both groups. Alteplase had a median age of 72, while the standard treatment group had an average age of 73. In both groups, there was a high percentage of males. Alteplase group had roughly around 55%, while the standard treatment had roughly 60%. And then looking at the medical history, I just want to take note of the hypertension, diabetes, and then current smoking status percentages, as they were kind of the highest of all the group or subgroup or the listings of patient characteristics. Hypertension being the highest of 70% in Alteplase group and then 73% in standard. Roughly 27% looking at diabetes in the Alteplase, 26% in standard treatment. And then looking at current smoking status, relatively similar, but Alteplase was 30%, while standard medical treatment was 31%. And then looking at the patient stroke evaluation, majority of the patients that were entered in the random trial were mainly identified as having no disability. And you'll see that in the Alteplase group being 95% versus the standard treatment of 92.5%. And then there was more, or looking at the NIH stroke scores for each group, there was a higher percentage of both groups being greater than 10, with Alteplase being 51% versus the standard treatment at 52%. And then looking at the large vessel occlusions, I just wanted to report that this was not part of the study, but really looking at the patient characteristics in this primary analysis, a great percentage did have large occlusions, and then very few had small occlusions in both studies. I mentioned that internal carotid artery had 17.7% versus 21% in standard treatment. And then looking at the M1, M2 segment cerebral artery occlusions, I got a total of 46.8% versus 48.4% in the standard treatment group. And then looking at the trial outcomes, primary outcome had an unadjusted absolute risk difference of 13.98%, which means there were better odds of non-disabled functional outcomes, which is great. And then secondary outcome had an average of MRS score of 2 in Alteplase versus 3 in standard treatment group. There were better odds of neurological improvement with the Alteplase treatment, but there was kind of a downside where there was a greater risk of adverse effects in Alteplase group. But really, the all-death mortality within 90 days were same with 11%, or roughly 11% in both groups. And I failed to mention in the last slide that parenchymal hematoma within 36 hours was also monitored in the safety outcomes. And then looking at the subgroup analysis, the primary outcome of patients that were included in the primary analysis, I really wanted to look or pay attention to this illustration because it really shows you Alteplase being better when compared with standard medical treatment in each subgroup, all besides the one section, which is the extracranial atherosclerosis. I also wanted to mention that the category of onset of stroke, it remained the same percentages in both groups that had an onset of stroke of greater than 9 to 24 hours. And then looking at the strengths of the HOPE trial, this was a random control trial that was multi-center design. That was a well-chosen patient-centered outcomes. This was a per protocol analysis that was implemented rather than just solely intention to treat. It was a balanced baseline demographics and stroke characteristics, imaging and tissue-based selection criteria, and then average stroke scores of greater than 10 on the NIH stroke score, which would equal moderate stroke burden. And then looking at some limitations of the HOPE trial, this was an open label design, single country, and then also, kind of glancing at the out of the 372 total patients, there was 180 that were enrolled in a single site. It was a short safety follow-up window of 36 hours when compared to what I've seen, which was like 48 hours time windows for adverse effects. And this was excluding thrombectomy, and this didn't really look at, if a stroke center having this availability. So maybe if a patient were to be given IVT and then, having to get a thrombectomy, there was no analysis of that. And then it excluded the severe stroke with an NIH stroke score of greater than 26. And then going into discussion, the HOPE trial demonstrates efficacy of Alteplase administration, the extension of 4.5 to 24 hours of symptom onset, really looked at improved neurological function and physical functional outcomes when compared to the standard antiplatelet treatment. This trial really broadened eligibility of patients that may have distal vessel occlusions, as well as strengthening IVT use in patients with large vessel occlusions that have salvageable brain tissue. This was a less restrictive perfusion mismatch imaging criteria that was launched by Extend trial, and then increase in symptomatic intracranial hemorrhage and parenchymal hematoma, but no difference in mortality. Really was utilizing imaging and likelihood for recovery as clinical criteria rather than time alone. Rescue thrombectomy occurred, but unlikely to sway results. And then I just wanted to put up values of the number needed to treat is 8, and then the number needed to harm was 31. And then looking at the conclusions, IVT with Alteplase between 4.5 to 24 hours found that imaging confirmation of salvageable brain tissue can be utilized in determining recovery along with time. And then there was greater proportion of patients achieving a non-disabled functional outcome when compared to the standard medical treatment. This increased adverse effect of symptomatic intracranial hemorrhage, but there was no difference really in mortality at 90 days. And then these findings support extension of therapeutic window for IVT in selected patients, appropriate when thrombectomy is not initially planned or indicated. And then these are my references.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.